Hi, everyone. I'm Anand Iqbal. Welcome to Digital Health on Air. I'm incredibly grateful today to be joined by Dr. George Lee. George is the Chief Innovation Officer at Asian Health Services. Asian Health Services is one of the premier leading federally qualified health centers and community health providers in the state of California, really focused on the San Francisco Bay Area community. They're headquartered in Oakland. We've been huge fans of AHS's work over the past 10 years while I've been on the Luma journey. And AHS really takes an incredibly innovative approach to keeping their patients, their people, and their community healthy. And of course, it's a very large area and an incredibly diverse patient population, and diverse in every shape, way, and sense of the word. So super, super excited to have Dr. Lee with us here to share more about AHS's work.
Yeah, thanks for having me on here. It's a pleasure to talk more about our health center and to talk about the work that we do.
Awesome. Well, I teed up a little bit of clearly I have a lot of love for AHS, but here our broader audience here, please share a little bit more about your organization, your patient population. We'll start there, and then we'll kind of dive into things.
Yeah, absolutely. So Asian Health Services is a community health center. We provide comprehensive primary care, dental, and specialty mental health services to about 50,000 patients all across Alameda County, which is in the San Francisco Bay Area. We have 6 medical sites. We have 7 dental sites, 1 specialty mental health site, and we have 2 mobile dental vans. About 91% of our patients are less than 200% of federal poverty level. 83% experience some type of linguistic isolation. We provide services in 14 different Asian languages. 96% of our patients are on either Medicaid, Medicare, or are uninsured. So this is definitely a population of great need.
So look, I think you rattled off a lot of different statistics there, but really, really important to help, I think, all of us understand some of the nuances you deal with. It's just not just about delivering care to folks who traditionally don't have access to it. There's a lot of barriers to care. They're underserved in a variety of ways, but you have the linguistic layer on top. Some are probably, obviously, the insurance mix you chatted about. So a very unique approach. And of course, you really stand out for your multilingual, like patient-centric, whole patient care approach. But as we've been studying your organization, as you and I have chatted, you guys are really taking this a lot farther, right? In terms of the actual structure of the service you provide to address some of these barriers and challenges and nuances. And really, as I think you guys frame it incredibly well, as opportunities. And so I'd love to dive into some of these really innovative things that AHS is doing to help more people get to the right care more frequently. And so I think one area of deep dive, and I know one of your personal passions is really remote patient monitoring. And so would love to learn more about the initiative and give us a bit of an overview, where it started, where you are, and really where you want it to go.
Yeah, it really came out of this desire. I mean, I guess first I'll talk a little bit about the overall vision, and it's really about this desire that our patients deserve the same type of care that we expect for ourselves. And sometimes, you really don't want to have that disparity and differences in the system of care. So that's really where it comes from the value. And then we started thinking about, well, if we look at the current healthcare system, how much of a patient's life is actually spent interacting with their provider? If you have, whatever it is, 3 15-minute visits with your provider, we just have to calculate that out. And if you have any guesses as to what percentage of their life is spent with a provider over a course of a year, 1%, 0.1%.
Oh, it's going to be sub 0.1%,
yeah, exactly.
right?
It's like 0.01% of their time, that kind of thing. So it was this desire to have what we were calling continuous care, or having multiple touches that are outside of those traditional phone models. And so that's how we started really thinking about this remote patient monitoring system. And we started first with high blood pressure because we had the most number of patients with that. We decided during the pandemic to actually, this is part of the AHS's philosophy, I guess. We decided to go for the hardest patients first. So we looked at our patients. We looked for patients who were monolingual, who had uncontrolled hypertension, and who had never had evidence of any sort of telehealth visit or video visit or something like that. So basically somebody who was probably digitally challenged and decided to work on that population to see if we could bring care to them. And so we started off with a small pilot. We had about 50 patients, and we brought them in. We taught them how to use the devices, et cetera. And by the end of it, we found out that 89% of the patients had either gotten to their blood pressure goal or had made significant improvement. So that was like, that's huge. Those are really, yeah. So that's how we started. I mean, when we started tweaking it, et cetera. But that was a validation of some of that process.
Okay, well, this is awesome. I want to get to like what's next and how you're thinking about expanding it. But I think, look, I love it. Like this frame and approach, I think healthcare, broadly speaking, can really benefit from, which is, start with not the low-hanging fruit, but really start with really your own desire. Like what is it that I would want as a person, as a healthcare consumer, as a patient, not just tackle the low-hanging fruit, but some of the hardest to reach fruit. And the lessons there can then apply to the entire tree in the forest. So I love this. So you started with very focused target audience group of folks, nearly 90% plus improvement. So massive, statistically significant, real impact.
Yeah.
How do you now focus on the rest of the tree in the forest?
Yeah. So there were a lot of things that we were learning along the way. And that was part of the reason that we decided to do it on a smaller subset of patients first, because we figured we could get a lot of learning from it. We actually took the time to, once we developed our team, once we gathered our team, we actually got them through a process where they thought through what was the type of care they wanted to receive, that sort of thing. So that everybody was on board with it. And then even with the patients that went through our pilot, we did a process of journey mapping to really try to understand what it was like for them at each of the different stages, because there was both the recruitment stage, there's device distribution, teaching them how to use it. Inevitably, what we found out was that they would go home and they would forget all the instructions that we gave them. Or it would be something totally random, which was, I turned the screen brightness down and I couldn't figure out how to turn it back up, things like that. So it really taught us quite a few lessons that we then are moving on with our other remote monitoring devices. So we've now expanded to congestive heart failure. And then we've also expanded to continuous glucose monitoring. So those are the three types of remote monitoring that we have now.
Awesome. And so tell us more about, you could pick, all three. You shared the statistics from the remote patient monitoring, type 2 blood pressure, talks about the other heart condition, and then chronic care really with the continuous glucose monitoring. Like, what are some of the results you're seeing there?
Yeah. So with the CGMs, the continuous glucose monitoring, we have most of our patients who are on insulin on it now, and we're able to actually make really good adjustments off of them. We're able to get their A1Cs down to a much more manageable level pretty quickly. And in fact, so much so that we decided to run a side project, because currently the insurance will only cover CGMs for patients who are on insulin. But we thought, we're having such great success. Is there a way that we can extend that to our diabetics who are not on insulin? So we decided to purchase some glucose sensors, and we ran another pilot with about 40 patients who are not yet on insulin to see what kind of results we get from them. And again, we saw amazing results in terms of decrease in their A1Cs. And so that we're actually looking to parlay into a larger study, what we're hoping to do. And then eventually the goal is to have insurances cover CGMs even for, not insulin diabetics. So that's our eventual goal, but we're starting to expand on some of these things. We're actually trying to publish some of our results to see whether or not I can add to the literature and hopefully be, part of the foundation that, insurances and other places could turn to for making these sort of changes. So one of the interesting things actually that we found with some of these things is that people make improvements just because they are paying attention to the particular parameter. So for instance, with the high blood pressure, we actually had two arms that we were looking at. So one arm was the blood pressure cuff plus coaching, so individual coaching. And then we had another arm, which was just blood pressure without the coaching. So while there were differences, so I said 89%, that was with blood pressure monitoring and coaching, but just monitoring itself got us into the 70% range. And so in some ways, we're finding that with the CGMs as well, so that the patients, even so the ones without insulin, just because they have now this monitor, they're starting to understand how to take care of their disease, and they're making changes. And, they do work with a nutritionist, things like that. But just the fact that they're really looking at their numbers and able to see, oh, wow, when I went to eat dim sum and I had my, whatever, it went this way, they're starting to make the changes right off the bat. So it's really cool to see the light kind of go off, the light go on in the patients. And that's what we hear from them.
That is awesome. Well, look, I think, one, these are incredibly well designed and thoughtful pilots you're doing, because they're clearly showing impact in specific patient populations, but you're able to really expand that to a community level, and with the research behind it to hopefully like a very, very broad audience. I know as South Asian, having certain metabolic conditions, and when you compare them to just general published averages, you could look okay or even green. But if you look at it for a South Asian, like, no, actually there's A1C, triglycerides, certain cholesterol readings that should be more alarming if you compare it to just a South Asian population. And so I think what you're doing there with your patient population will be incredibly impactful for the research from a broader public health standpoint. You mentioned focusing on folks who are on insulin, expanding it to folks who are not on insulin. Are there plans to just make this available to like pre-diabetic populations as well, and think of it at a much larger community level?
Yeah, that's interesting that you bring that up. We are so the things with CGM is a little bit harder to deal with, just because there is a particular cost to it that that insurances would need to cover. But we are definitely moving into looking at ways that we can prevent disease as well, because that would be the best. And so there's that cartoon where there's like a faucet where there's water going into the sink, and then the sink is overflowing, and then things are spilling on the floor, and you've got people that are using the mop to mop up the stuff on the floor. So it seems like a lot of our current healthcare is figuring out how to mop the floor, right? And to be able to have the best treatments for your diabetes or whatever it is, but that's all still mopping the floor. So the goal is to turn off the faucet, right? So that things aren't coming down, and the whole idea of prevention. And so that's actually another thing that we've done this past year, is we have a grant where we're doing teaching kitchens, where we are teaching some of our patients how to cook in a more healthy way, and there's certain particular principles. So we basically have a group, and then we work through a recipe, but we're also working through, okay, how do you make healthy substitutions? What are different ways that you can make improvements? And we're actually asking them to bring a friend or to bring a decision maker in their household, because we also know that changing the way a household cooks and eats is not just an individual decision, but that it's really more of a community one. So we're playing around with that at this point.